Welcome to this month's Fire Chief's video message for the month of August 2018. As we begin the fall year, school is upon us. We're always in school as we are here in the department. This month, one of the things we're focusing on is our eMEDs Elite rollout. Joining me today is Tim and Megan. You've been integrally involved in the transition from eMEDs to eMEDs Elite. You're here today to help explain the why, explain the benefits of. So thank you for joining me. Thank you for the time that you all put into making eMEDs Elite, which is very opportunity available to us to make it something that helps us work better and help us and the providers of MCFRS use it better, which we didn't have with eMEDs. So what's the key highlights that eMEDs is Elite or eMEDs Elite is going to help us with?
So everybody always wants to know why we're making these changes, so they feel like it's not something arbitrary that we're doing. As many of you may or may not be aware, the patient care reporting software comes from eMEDs, and eMEDs changed or decided to change this software a couple of years ago, and they've been working up to it. For them, it improves it modernizes the data set. So one of the things that they do is they report to a national database called NEMSIS, National EMS Information System. This brings the data set up to the latest version of NEMSIS. It automates a lot of the reporting that they do to things like the CARES registry, which is the cardiac arrest registry to enhance survival. Right now, Captain Lindsay in the EMS Quality Improvement Office hand binds that data and fills out a report once a month and enters that in that database. This automates that process, so to make that a whole lot easier. So for MIMS, there's a lot of benefits to it, but the department itself has chosen to seize this opportunity of the modern platform that we're going to make three real major improvements. Right. So for us, we're going to make patient care reporting more friendly to the end user. So the provider in the street who's actually using this and running 10 calls a day on Medic 708, we really wanted it to, at the end of the day, be an enhancement to what they do, make it easier on them. The other thing that we wanted to do is really customize it to the data that we're looking for as a department. We've made, the department has things that it looks at and things that we want to focus on, and we want to know how we're performing. So we were able to make sure that we were getting the data out of the data set that, the data that goes into the data set is available for us to look at.
Right, so only a little bit of the data comes from CAD into eMEDs.
Yes.
The majority of the data that is put into eMEDs Elite is from the end users typing it, touching it onto the screen.
Right.
And we were allowed to customize some of that data fields.
Yeah, make fields required. So the data set itself is the data set, and that's coming, and the form is coming from MIMS, but we were able to highlight certain fields that we said we either to remind folks, hey, we really need this field filled out, or to not make it so that it's required, not turn it red, as you'll see in the program.
Okay, and then the how long has it taken, or how long have we been working to get it ready for us and
So yeah, so I would say that our first visit over to Queen Anne's County, Queen Anne's County and a couple of other small jurisdictions on the Eastern Shore went live with Elite in the beginning of this year. A bunch of us from the EMS section and from IT did a field trip over to the Eastern Shore to visit with Queen Anne's and see how it was working for them in March or April. And shortly after that, we got our hands on the program and started looking at what we wanted to customize, how our stuff integrates, and getting it all set up. So I would say about 6 months or so.
6 months. So what's involved in making the patient care report more friendly for the providers on the units?
So when I was riding medic units and doing a lot of EMS reporting, and I still do some EMS reporting as far as data entry goes, it used to drive me nuts when I would have to enter fields the same way on every single call. One of them, for example, is the lights and sirens. how did we respond? As an organization, we know that for almost every call, we respond lights and sirens. So I didn't understand why did I have to click on that field every single time. And as you'll see, a lot of the in the figure, a lot of the things that we know or that are already entered into CAD will come directly from CAD. So we had it programmed. We worked with Image Trend, and we had it programmed so that on any call, alpha through delta or alpha through echo, we know that we're going to go lights and sirens. So it automatically comes up as responding lights and sirens. For the omega calls, it says no lights and sirens. For anything else, some of the, like the police PIC or some of the stuff may not come across or may come across as something wrong. So you'll still have to verify it, but for the most part,
right,
fields like that are going to come are going to be populated automatically and reduce the number of clicks that the user has to do, especially on some of these fields that we already know the answer to.
Right. And part of the data that we're going to get now, hopefully, will be coming from, I'm going to say that the QC code, QR code on a driver's license. Help explain that. Yeah, so that's that was one thing that I was really happy about when we found out the actual functionality of it. I first thought it just scanned in the Soundex number, but apparently there's a national standard. On the back of everybody's driver's license, it's a barcode, and in that barcode is a huge amount of information. It's your first name, last name, address, height, weight, a whole bunch of stuff. And you'll see in Elite, when you scan that, it'll zap it into the report. It'll ask you to verify it, and then all of that information will automatically populate into the correct fields in Elite. That's something that's done. There's a barcode scanner on the tablet itself that's currently there. It's not functional in the legacy eMEDs, but it will be in Elite, and I think that that's going to be a big functionality for the end user, not only because it reduces the amount of things that fields that they have to type in, but it also improves the accuracy of there's not any room for typos. And there's no Soundex does not come over, correct? Driver's license number does come over. Okay, but so that's definitely an improvement. So what about the LifePack interaction between the Elite and our LifePack 15s? In legacy eMEDs, we were limited to the things that we could enter as events. There had to be a pre-programmed code in eMEDs that it had to match up. In Elite, it was sort of a blank slate. Anything that we entered in Elite, any text that we entered into the LifePack, we could match to any procedure in there. So what we did is we did a focus group with, I think it was the 30 or 40 busiest paramedics in the county, and we asked them, what do you need? What do you like about the event list? And we came up with a new event list, a new strategy for it, and then we mapped all of those into the new Elite. So hopefully what users will find is that the events that are available to them are more relevant to what they do. The process of where they're located are more relevant to what they do, and then the functionality of actually bringing it into Elite will work better. And one of the other things that Elite's doing is that predetermined dosing data? How does that work? So I had gotten a bunch of feedback from folks, especially in that focus group. If I'm entering EPIs on a code, why do I have to enter, if I push EPI 1 to 10,000, for the most part, we know that it's going to be 1 milligram, either IO or IV. Why do I have to do that every single time? So what we set Elite up to do is when you hit EPI 1 to 10,000, it defaults to 1 milligram IO, which is the most frequent dose and route of administration. And it does that for pretty much every medication that we administer. It has a default dose. Now, in certain cases, say a pediatric patient, weight issues. Yeah, you may have to go back and adjust that. But again, we tried to get the largest volume of how we use that to be the default. So all of these things are automated actions or integrated capabilities that, as you say, and as we want to communicate, improve the information that the providers are putting in, because it's preloading it, or it's automatically preparing it for validation as opposed to manually entering it.
Right.
And that dovetails into the improved data of patient care reporting, and how eMEDs at Elite is intended to help us improve the reporting, the narrative, and the documentation that we're creating. So how does that help the providers, and how does that help the patient?
So we use, in the EMS section, we use the data that goes into eMEDs for a lot of things. Chief Bush will tell you that probably more than 50%, at least 50%, more than 50% of the protocol changes that have come out in the last 5 years have been driven from within Montgomery County. And in order to do things like get the protocol changed at the state level, we have to be able to justify that. We have to be able to use the data that we have to say we really need to make this change. Okay. So we're the other thing, you know, there are some we use the data to figure out on a system level how we're performing, what are the biggest things that we need to change to keep our patient care up with the latest science. And we use the data to justify purchasing new equipment, not purchasing new equipment, driving the direction of the patient care and the focuses of patient care. So we're using this data for a whole host of things. Unfortunately, the integrity of the data set that comes into the legacy eMEDs program is not what we'd really like it to be. The other thing is that we want the people that are doing the work to receive the credit for it. So when we go to meetings at MIMS and we talk about their performance indicators, our true performance is not really reflected in the data set that they're showing us and then sharing with the rest of the state. So what we wanted to do, one of our goals was to improve the integrity of the data set, make sure that when somebody is giving an aspirin, say, to a chest pain patient, that they're reminded to document it. Not only to justify the fact that it was an ALS call, but to just be an accurate representation of the care that they gave.
And you have a couple graphics that reflect that data components, and, and the first one is ACS, bundle. Explain this picture that you have on the screen here.
So we look at things called bundles of care, and they're 5 or 6 things that we want to see in a given situation with, and this data comes out of the First Watch, First Pass program. And for a patient who's having an acute coronary syndrome, we want to see that they did get oxygen if their pulse ox was less than 94, that they didn't get it if it was greater than 94, did they get a 12 lead, did they get aspirin? So to this bundle of care, all these things that we want to see have happen. So as far as the oxygen goes, that I'm pretty confident in that number, but did only 85%, the data reflects, without looking at the too deep into the narrative or calling and asking the provider, that only 85% of patients with acute coronary syndrome got a 12 lead. It's certainly not what I'm seeing when I'm riding in the field. Right. I can't remember a patient or being involved in a patient care scenario where a patient with acute coronary syndrome didn't get a 12 lead EKG. So what I'm thinking is most times, that's where the EKG didn't get downloaded into the EPCR, or for some other reason the EKG didn't get documented. Right. You're right. Same thing with the aspirin. Only 65%. The data reflects, the raw data reflects that only 65% got aspirin, and only 42% had an IV established within 2 attempts.
2 attempts, which you know from physical seeing, as you say,
right.
That's unlikely that we're going to be beyond 2 attempts for an IV on a patient that frequent. Right.
So the data validation, there are reminders set up in eMEDs that will remind folks that, it'll say, hey, you had a patient with acute coronary syndrome, did you give an aspirin? or did you start an IV? There are reminders set up called validation rules, and fields will turn red, and based on, it's all situational. So if you select acute coronary syndrome as a primary impression or chest pain as a primary impression, it'll look for those fields to be entered and remind the provider to enter those.
Right. And the other data set here that we have on a slide is medical cardiac arrest, or what does that information show you?
So right. So with the cardiac arrest, we know that everybody's in cardiac arrest, their rhythm gets assessed, right? But it's not reflected in the data set. Some other things, the use of a video laryngoscope is only 42%, I believe, and that's or less than, so 18%. I'm pretty much seeing that video laryngoscope used on every intubation. So again, I don't think that the performance here that's played out in the raw data coming from the legacy eMED system is what's actually happening.
Right. And the goal is, as you said, some of the protocol changes and some of the equipment changes come from data, i.e. the video laryngoscopes coming from data. Secondarily, the goal with Elite is going to help us get improved accuracy of these bundle reports and this data set to say, on a cardiac arrest, we did use an advanced airway more than 20% of the time. So definitely positives for us to do QI, QA on our activities so that we can provide the high quality of care we do. We have an amazing ROS rate and HPCPR as a result of a lot of science and collective effort that we as an organization did and pushed that process. I mean, Bob Lindsay did it as the B-Shift test bed, for a long time. What's another benefit that the transition to Elite is going to provide the department?
So just like it improves our data set to be able to look at the quality of care, it also improves our data set in terms of what we can, our billing. So there's a couple components to the billing process. One is just having the proper information so that we can bill the insurance company, having the patient's proper information, having all the signatures in line, having the patient's address. And through the validation, we're able to do that. But then the other part is justifying the medical necessity of the transport. And that's really the in-station training that we've been able to do has focused on that. But in terms of the data that the data set and improving the integrity of the data set for billing, back in last December when I first became involved with First Watch, we wanted to see what we could do with the program. So we did a 2-week push of emails, targeted emails to providers where they were missing a critical element for the billing process. And if you look at the graphic, you can see exactly when we did that, and we got, this is a run chart of the number of tickets that were missing one of the critical elements. And you can see where we did the intervention, and then we got a notable and sustained change throughout the present time. But at the best, we only ever got to the point where there were still 300 tickets a week that were missing one of the 11
and a ticket is a patient report.
Right, yes. A billable, transport. So if you use the modest sum that one ticket is worth $300, that's $90,000 a week, or almost $5 million a year that we could potentially be leaving on the table just because we were missing a piece of information.
Right.
Now, we understand that there are reasons why people don't get it, and we'll never get to 100%, but we've built the validation rules around minimizing the number of those billable calls where we're not able to bill just because we're missing some information.
And one of the things that we did a while back, and it does go back a while, is if we can't get a good, accurate, Social Security number, is the insurance that we're putting in the 999, 99, 9999. So that is a completed field, and then the interface with the hospital data allows us to cross-check their information. But if we don't have that report, with incomplete Social Security is going to become another problem, another report that is causing a hurdle to successfully match them up. And that's one of the things that benefits us is the ability to match those reports up, our reports, the hospital's report, and do that so we can do the appropriate billing. As we go forward, how's the reaction to the training? How's the reaction to the online training and the reaction to the in-station as we're, in-station training is going on as we speak?
I think the overall feedback that we've received is that it's been beneficial. A lot of providers didn't realize how not getting a Social Security number impacts the billing process or getting the signatures. So Tim did a lot of work to make sure that we are reminded to get the nurse to sign, to get the patient to sign when they're able to. And then if the patient is unable to sign, there is a process that we have to go to that's a little bit different than what we're used to having to have done in the past with our current system. So we've been discussing that in class as well, and there will be a matrix on the top-up for them to follow because, like I said, it is a little bit different than our normal process that everyone's used to. And again, if we can't get the Social Security numbers, there's a reminder there. It'll stay red on the report saying that, hey, at least try to obtain the patient's Social Security number if you can. We talked about different ways to do that in class. Then we really focused a lot on the documentation aspect of it, how our documentation is important for proving medical necessity, which is what insurance companies do look at when it comes to the billing process. We talked about writing appropriate documentation, chart narratives, making sure we do a head-to-toe assessment, talking about our interventions that we do, just so that when the report does go to the billing process, it's billed appropriately and correctly, right, and it's thorough.
And one of our goals with this training and the transition to Elite was to improve the platform and the interface that the men and women of the MCFRS are using for that. One of our goals of this video session as part of as well as the in-station training is to show what is the value to everybody who does the report to use Elite and what that brings the benefit of it. And there's a lot of capabilities because what we're doing today will make changes 5 years down the road. Will improve the EMS care for as you said, Tim, the protocol will be adjusted or the system of delivery will be adjusted. And there's a lot of things that we don't think about in the here and now that do result from good documentation and the good data components, which will change, and in a few years from now will be something saying it's because of this, because of the information that we were able to gather, we were able to present the necessity for, the need for, the benefit of this capability, and that's coming from data. So I really appreciate everybody's hard work in taking the training. I appreciate all the folks, the DOs and the folks from EMS section and the folks that are out there doing the in-station training. To get that done so that when we do the cutover, it'll be much more smooth. I'm going to use that phrase because there's going to be hiccups, there's going to be bumps, and when this is a change, we all kind of have that resistance to change. I mean, we were talking beforehand that school's upon us for our school-age kids, and the summer's over, and now they're changing back, and it's just a rough time. So, just like kids going back to school. Our providers going back to school talking about a new software system and how the reporting is a bump. So thank you for the work that you all have been doing, everybody in the EMS section, about preparing for Elite and getting it to that. So really appreciate you coming today and such. Anything last to cap about the transition with Elite?
Just that as folks get it in their hands and use it, and if there's things that they like, don't like, things that they want to see changed, I'm happy to receive those and change what I can, or at least discuss it with people. But we have a lot of local control, and we're happy to. We want to work with the folks in the field to make it usable for them.
Right, and that's a good thing that it is a capability for MCFRS to make those local control points where we can, versus something that's just absolutely fixed and locked and immovable. So good stuff. thank you very much. And the topic about data and eMEDs and patient care reporting is very much dovetails into the accreditation activity that we, just about 2 weeks ago received accredited agency status from the Commission for Fire Accreditation International, and that is a purely heavily data-driven process, as many people within the organization participated in writing up the list over 250 criteria and performance indicators, and accreditation is driven by the agency, driven by the executive branch, as a means to which we strive to improve by having metrics, measuring that, always setting the bar for the need for improvement and identifying those gaps. So it was a great opportunity and honor that we were able to go to Texas at the Fire Rescue International Conference and sit in front of the commission and receive that accreditation. And the work goes to Chief Carr, Bowers, Lohr, everybody within MCFRS, because this is our third cycle, started in 2007, and it is definitely a well-earned and well demonstrated the effort that we do towards self-improvement and measurement, and that's a good opportunity. Also that we had at the IAFC conference was the opportunity to support Glen Echo Chief Herb Luce, as he was the recipient of the Volunteer Chief of the Year for IAFC. Chief Luce has been with MCFRS for a little over 20 years, and has been a member at Rockville as well as now Glen Echo, and he was the IFC Volunteer Chief of the Year, and that was a great opportunity to have a member of our organization highlighted by IFC. At the same time, it was great that we brought on another key member of our organization, Anthony Ramirez. He's a gentleman who is now the car seat manager, as we would best describe it. He has joined us recently. Anthony comes from a line of National Highway Transportation Safety Administration projects, which focused on community safety, traffic safety, and impaired driving. So he's got a lot of history and national projects and focus on those activities, and he's got a passion for safety, injury prevention, as well as delivering high impact programs. So he hit the ground running. He is going to be picking up the car seat program and getting that progressing forward and moving on. So those car seat techs probably have already heard from Anthony. Those folks that are going to be involved in the car seat program at some point, that's who Anthony Ramirez is, and I want to welcome Anthony to our organization. And as we definitely have a focus to prevent the 911 call, and one of those is keeping our community safe, and car seats has long been, many decades now, has long been a program by which we do that. So a lot of stuff going on within MCFRS, and these are just a couple highlights and examples of that. So anything else in the EMS front that maybe coming out soon?
No, we just got through we're finishing up the protocol cycle for next year, so there should be some interesting and great changes to the protocol that happen then. So we're just moving forward.
Excellent. All right. Well, Tim, Megan, thank you very much again for joining us here today. For everybody who is sitting in one of the in-station training sessions for eMEDs Elite, and those that are preparing to turn it on as we go forward, again, continued training is a way of improvement and improve our processes and improve how we help the residents and visitors to the county. So as we go forward, school's about. Yellow buses are soon to be rolling around. Make sure we watch out for our children walking to and from school, and the additional traffic flow reference the schools being open. We will know the traffic will increase as the summer ends. There's no doubt about that. And as we continue to move forward, everybody take care and enjoy the last few days of summer.